We're live.
Thank you. It is 10 o'clock. I will call the Board of Health meeting to order. Welcome, everyone. It is Friday, July 23rd, and we'll start with the roll call, please.
Sue Patterson,
Present.
Alan Barfoot,
Present.
Brian Milne,
Present.
Brian O'Leary,
Present.
Chris Peabody,
Present.
Mitch Tulin,
Mitch has sent regrets.
Selwyn Hicks,
Selwyn will be joining us. He will be a little late. He's got back-to-back meetings.
Helen Claire Tingling,
Good morning.
Janice Jackson,
Present.
Nick Saunders. Nick Saunders,
Okay, we do have quorum. Thank you, Mary. So we'll start with, are there any amendments to the agenda? Seeing none, I will ask for a motion, a mover and seconder for approval of the agenda. I need a mover, Brian O'Leary and Helen Claire Tingling. All in favor? Carried, thank you. Item 4, does anyone have a disclosure of pecuniary interest or a conflict of interest? And I don't see any, but if one should arise during the meeting, please declare it then. Item 5, adoption of the minutes. So we have minutes from June 25th. Is there any discussion? Alan?
Sorry, I moved the motion.
Thank you. Moved by Alan, seconded by Brian Millen. All in favor? That is carried. Thank you. Moving on, item 6, correspondence and news releases. We'll start with the correspondence. Drew?
Thank you, Madam Chair. And through you, I have 3 items of correspondence to present from Windsor Essex County Health Unit, North Bay Perry Sound District Health Unit, and Southwestern Public Health Unit. All 3 correspondents are looking at funding and particularly the mitigation funding and asking for funding expectations from the ministry in 2022.
Thank you. Any questions or comments about that correspondence? I don't see any, Drew. Please move on with the news releases.
Well, as you can see from the list, fairly busy communications department over the last, since the last meeting. A couple of media releases I'll actually draw your attention to. Early on, the interchangeable vaccines, that's when Moderna and Pfizer were coming. June 22nd, I want to highlight the support we've received from Chapman's and their substantial effort towards the vaccinations in Grey Bruce. Late June 23rd was when the Hanover outbreak was declared over, and subsequent to that, we had a youth-only vaccine clinic in Hanover. And we began a series of situational updates to bring public up to date on what we're doing throughout Grey Bruce. And we also started weekly media releases with respect to clinic schedules as the clinics were really ramping up with drop-in and walk-in. We did a call for vaccine hub volunteers, which went quite well. A couple of items on summer gatherings. We wanted to acknowledge that summer was coming and give people some guidelines. We talked about Canada Day and had a very successful Canada Day vaccine clinic in our own parking lot. Also, with respect to vaccines, new clinics were being added and expanded. We gave some guidelines for people participating in the Indigenous residential children walk on their behalf. And then in July, we began work with Saugeen First Nation as they declared an outbreak or a state of emergency, pardon me, in response to emerging COVID-19 in that community. Early July, Owen Sound's immunization clinic relocated to Owen Sound District Secondary School. And then again, more vaccine clinics. And then we set up a media release with regard to mass immunization targets and hoping to get everyone done vaccinated by the end of July. In July 8th, we were identified by the province as a Delta variant hotspot, which changed the dynamic of what is happening with the infection in Grey Bruce. And July 9th, we had a media release with Bruce Power, encouraging vaccine by providing a golf game with Doug Gilmore as an incentive prize. And into July 11th, there was another outbreak declared with regard to a young people's event near Chesley. Again, there's a few more media releases with regard to our pushing the vaccine to get the virus and booking issues being resolved, and then with the province moving to step 3, we provided a roadmap for a modified step 3 in Grey Bruce, and that's a quick highlight of a lot of work that went on in late June, early July.
Thank you, Drew. Yes, a lot of communication happening. It's very good, very thorough. People really appreciate it because they can, if they miss it, they can go back to the website and check it out. Alan?
Just have a question. I think one of the strongest messages through the media release that went out the other day was the amount of new variants that in our area, people getting that are unvaccinated. That 95%, I think, number rings a bell. and I know Drew and Dr. like you do a phenomenal job of getting messages out, but is there a stronger way to get that message out to the general public that if you're not vaccinated, you are so susceptible to spreading this? I mean, we're still the hotspot on Ontario, basically, and somehow we have to get that message I think into more ears, but I don't know how we do it.
Thank you, Alan. Dr. Era, did you want to comment?
Certainly, through you, Madam Chair. Today's presentation builds on yesterday's presentation to the Grey County, and the material, we have enough cases today that we can share the analysis without threatening privacy. So the whole material will be available for the media on Monday. We plan to provide that piece of information that you rightly identified. The 95% of the cases are people who are not fully vaccinated, and that is core to our messaging for the coming 6 weeks as well with the targeted immunization. More information will be on the update from the MOH in the next item.
Okay, thank you.
Okay, thank you. So could I get a mover and seconder to approve the correspondence and news releases as presented? I need a mover. Alan, and seconder Brian O'Leary, all in favor. That's carried, thank you. So item 7 is the Medical Officer of Health update. Dr. Era.
Thank you. I'm just going to share my screen, Madam Chair.
Yes.
So that should be on the screen, and
Yes, it is.
so overview of today is in general 2 sections. One about the surge in the Delta variant, and the other one is about the vaccine, which is the long-term solution. It's worth mentioning that active outbreaks in high-risk settings is quite the same. The risk of transmission in these settings has not changed than before. There we have one child care outbreak, and it is 2 cases only, and it's nearing closure or declaring over. What we've seen in the past Sorry, my screen is covered a bit, so I just have to move stuff around here. What we've seen over the past few weeks, 4 weeks or so, has been different than before. If you look at this graph, it's an epidemiology graph. We've had this baseline less than 5 no cases per day before June. And when the Delta variant arrived, the first identified case was on May 26. Then the Hanover roaming home outbreak took place, and this is the bulk of these cases. You can see after that, similar outbreaks taking place. There is a pattern there. We put out the fire, it comes back on in different location. And there is some artifact there related to weekends. On weekends, whether it is people don't like to go get tested, or there is a slower process in some labs, you would see this dip. However, the artifact does not explain the pattern. Rather, the pattern is clear. There is an average around 20 cases per day, 20 new cases per day. So the measures for case and contact tracing that we have in Grey Bruce that have proven superior throughout the pandemic, we can bring down the numbers to close to 0 when we apply it. They are the same measures. The difference is we take control of the situation in 1 week, we bring it down in 2-3 weeks, but during that time, there's another event, another event, and another event. So the past 4 days have been the first 4 days where the numbers didn't go up to 30 or the average 20, rather the average is around 10. You can see 11, 5, 15, 15, and today's report is going to read 8, which is good news on a right path. But to have a reassuring picture, we need more data. We need more days similar to this. Last week, the discussion with the Chief Medical Officer of Health Office in Public Health Ontario was about going to stage 3, staying in stage 2, or modified stage. And according to the provincial assessment, based on the where the Delta variant became the dominant variant, based on that assessment, we would have a trajectory of maybe 10 weeks in the same situation, where we have enough control to keep a lid on it, to contain it, but not to wrestle it to the ground. I'm not convinced with that assessment, just because I know the parameters and the response and the collaboration that we have in Grey Bruce has been providing us with different results than the general result in the province. So generalizing the experience from Waterloo or from other area to say the outbreak took, or the surge took 10 weeks is reasonable in many ways, but I would want to respectfully contest it and see if our response would wrestle this to the ground with case and contact management. Of course, vaccines will be the only way out of this. We will wrestle it down to the ground, but it's going to be, if we are successful to bring it down to close to 0, there will be other surges until we reach the herd immunity. So the target for herd immunity was 75% and 70 to 75%, and we nicely achieved this trajectory for it. The hard finding last week in that discussion, and now it is known, I believe, the Delta variant has a herd immunity around 90 or a bit over 90%. So it's a different target. And the hard finding also last week that 99% of our cases are Delta variant. So we're not dealing with the same pathogen. We're dealing with a different pathogen. And again, one of the metrics is our case and contact tracing. The robustness of it has been successful to control COVID whenever we deploy it to close to 0, versus the Delta. We can contain it, and we've been able to keep it under around 20, but we have not been able for the past 4 weeks to bring it down, and that's main difference. Gonna go to a few other slides, Madam Chair. The first point is what Mr. Barfoot alluded to. The majority of transmission is in individuals who are not fully vaccinated, 95%, and that rate or number proportion even is more stringent when it comes to hospitalization and death in the provincial data or national data or international. Our data sample size remains small to make inference from it, but CDC Atlanta mentioned that 99% of hospitalization is in people who are not vaccinated. We look locally and we see that there are two main drivers of this surge. It started in the transient community, low socioeconomic status, crowded housing, people who, to start with, have a challenge in dealing with different aspects related to this. And now we see that it is also in private gathering parties in younger individuals, teen and 20s. And I will explain or showcase in the next slide some of these aspects. Both groups have high number of high-risk contacts. Our teens and people in 20, they're socializing with many individuals, and they're attending many activities, and there is messaging that designed specifically for this. It's going to be sent to the public and to parents, to different stakeholders, to emphasize on our need to call for help from these groups to actually alter their behavior. And I have full confidence that the younger people transmit the virus innocently. If they feel that it's not going to affect them severely. But I do believe if they realize, if they're aware that their behavior is going to transmit the virus to somebody else who's going to transmit to somebody else who's going to be vulnerable, their behavior will be altered. And the second group would, and we have been over the past 4 weeks working with partners to provide alternative housing, to provide different services that are needed for this group. And we've been successful in putting out the fire whenever we identified the Saugeen First Nation is a clear example, an outbreak of over 100 people. It was, the resources have been deployed, working with partners has been in place, and the control of the outbreak took place within the first week. Then after that, we're seeing, any cases that is being identified, most of them, almost all of them, I would say, to my knowledge, have been people in isolation. So there is no additional risk to the community from them converting to cases. Rather, we're following up with them, and it's part of the process. Out of the 120, now we have active cases of only 13. So this is on a good trajectory for being cleared. And in different locations in Grey Bruce, again, you would find these two groups or two groups of our population being the main driver. Workplace regulated settings, for the past 4 weeks, the risk has not changed. And probably the next slide, again, as I mentioned, with the number of cases, privacy is not an issue at this point, sorry. So this is social analysis. Dr. Zayed is leading the work on it. And it looks at the number of cases in Owen Sound. We have another set for all Grey Bruce, and for each area we focused our work on, but this is a really good example. These are the cases, the dark blue. If we add to that the high-risk individuals, light blue, we get this.
Dr. Era,
I see.
we're still on the previous slide.
Okay, I will correct the technology. Sorry for that. Instead of using the slide, I'm using the PDF, and that is. Sorry, I'm trying to share the screen, but it's giving me a hard time. This should be all right.
That's
Thank
good.
you. So this is social analysis for the cases in Owen Sound, and it provides a good example of the previous slide and the conclusions in it that has been the guiding principles for our management. And if we add to the dark blue, the light blue, high risk, the picture becomes more complex. However, there is a lot in it to be learned. So if I zoom in, or if I start there, you would see the main drivers are low socioeconomic status, and some of these crowded homes as well could be connected to this. The other one is the younger people. This is a party outside of Owen Sound. However, these are the Owen Sound residents that attended that. And this is not the entire event, but there is enough complexity and interaction among people that led to this higher number. There are workplaces here that have been investigated, over 12 of them in this graph. And you will see from that, just gonna walk through it. There is a hospital here, and there are 2 cases who were admitted to a certain ward. There was potential exposure to, or exposure to 4 individuals. All of these have been cleared, no transmission. There was a restaurant attended by one of the people who attended the party, another restaurant exposure of only 1 person, exposure of 2 people. Both of them are clear, no transmission. The real control happens in the healthcare system. Doctor's office, a patient was there, no exposure to anybody. Retail store, retail shop over here. And this is it's a bit of not easy story. A transient parent with a transient child. The child visits the other parent who lives with another partner, and transmission takes place. Both individuals work in the same location and they carpool. That's the other. So there's transmission either here in the home and they went to workplace. And again, in the workplace, we identified high risk. The investigation followed them. They are cleared without converting to cases. Another proof that the workplace risk has not changed. The long-term care, a case visited and no transmission. Retail shop, another one. There is another controlled setting or regulated setting. Childcare, a number of people, children were exposed, no cases. Another childcare, only 1 person was exposed, no cases. So with this picture, there is high level of confidence that our regulated settings, organized events, and that's where the step 2 to 3 really matters, because these are the locations that are controlled by these steps. There's no change. The main change, as I mentioned, in the crowded housing and low socioeconomic status and in younger individuals' parties. And that's where our recommendation to move to a modified stage to limit the number of social gathering to the same stage 2, but it is recommendation, not order. We can always go to an order if the least intrusive approach didn't work, but our experience with the public in Grey Bruce and the community has been favorable throughout, and we know that people are fatigued. So adding more restrictions might be a penalty for people who actually did the right thing. This is a picture for all Grey Bruce. So that's the same party, becomes way more complex, another event. All of them are nicely controlled. And again, I was asked, you say it's controlled, but the number is around 20. So long as we're following the cases within 24 hours, that's level of control. The social analysis would allow us another level of control. And again, I'm cautiously optimistic the experience that took place in Waterloo or other parts of the province might not be generalizable to Grey Bruce, and that we are going to be able to bring it down in the near future to close to the baseline. And nevertheless, the the solution would be in a vaccine, and that's the second part of the update, Madam Chair. Late June, we had 24% of our population vaccinated 2-dose. We have not, we have always been low risk areas, so the allocation was less than the priority in hotspots for, according to the provincial direction. As soon as we saw the surge and the Delta has been identified, I want to thank everybody around the table for their advocacy and support and allowing myself and the team to communicate with the ministry on behalf of the community to say we need immediate larger supplies. And the support from the ministry has been unequivocal, very, very strong support. The MPPs have played a strong role, MPP Walker and Thompson. And the chair and myself met with Minister Jones on that visit to the hub in Peel. We utilized that, capitalized on that opportunity to describe the situation that we're projecting we're going to be dealing with, and the supply came in. Specific little detour, 2 minutes, and I'll come back to the update. I just want to thank the volunteers from the municipalities, from the public who helped us over the long weekend or the staffed holiday. That was a unique juncture. The ministry said we'll send you 11,000 doses, and we said we can utilize, we need 25,000, and we can utilize that effortlessly. And there was a need to showcase that, and we did. And after that weekend, that week, the ministry sent 25,000 or more if we needed. And the work of the volunteers on that long weekend was critical, because many of our staff have already scheduled the holidays long time ago. We were in a baseline that's manageable to approve these vacations. Our volunteers as well, many of them have had plans. And for us to operate all the hubs, or most of the hubs, most of the days, we needed more staff, and we raised the alarm. We called for volunteers, and people supported. And on that weekend, during that 7-day period, we administered over 26,000 doses, and we allocated 36,000. So that was the showcase to the province that yes, we have capacity and we can finish the job. And going back to the slide, by July 15th, we went up from 24 to 60% 2 doses. And that is close to half of our population in a matter of 2-3 weeks. Currently, we sit around 75 for first dose, 65 for 2 doses. And those numbers, if you look at the provincial website, they're actually higher for Grey because the population we use is from census for 10 years and older, versus the province used different denominator. So my understanding, last time I looked at it yesterday, we were the highest in the province for 2 doses. The average was 63. We are at 65 in our numbers, and a bit more in their numbers. And I just want to emphasize the work of the staff, the volunteers, everybody, the communication to ensure this happens has been again turning a challenge to a success, a partial success, until we get full control of this pandemic and have the numbers high enough to control the Delta variant. We cannot call it a full success. This is the picture, the graph in late June, and you can see the dark color is 2 doses, people with 2 doses in Grey Bruce. Light color, people who received their first dose, but they have booked their appointment either August, September, October, or they have not booked an appointment yet. Over the curve, this space is people who have not had any dose. So the group under the curve are the people who bought in, the people who know they're not going to be allowed, they need their second dose. And for the past 3 weeks, especially the first 2 weeks of July, our communication, our messaging is targeted for this group. And we left no method unused. We communicated with the people who have booking in the booking system by email to ask them to rebook earlier appointments in July. We worked with the ministry the initial plan is to communicate with them through the public, through these emails. And if there was a response, that's great. If not, we can up the measure to actually request cancellation of these appointments for an earlier appointment. The word cancellation sometimes sends a negative message. So we went with the least intrusive communication every day with this group. And we've been bringing that number from around, I believe, 16,000 people. Right now, they sit around 4,000 people who have booking in the future in September and October. And we asked them to go to July. At the same time, we communicated to the public, to the partners, primary care, to encourage everybody to encourage their patients and pharmacists to get more doses. And you can see how the dark color increased significantly. Going forward for the coming 6 weeks, our goal is to communicate for this group over the curve. You can see between 12 years old to 40 years old, there is less than 70% vaccinated first dose. And we know that this group, many of them, it's just vaccine is not on the radar. It's not like they're anti-vaxxers. So we will, in our communication or work, we'll focus on two fronts: access to ensure targeted clinics and attend to all the location that these individuals are, and communication as well from different areas or from different junctures. Probably the next slides will explain what I was trying to explain verbally too. This is a bigger picture at this point, or from 2 days ago. The strategies for immunization, there is mass immunization, targeted immunization, and the long-term sustainable, and I'll mention it quickly in the next slide. You can see the mass immunization has done its work very nicely. We reached around 70-75% of the public through mass immunization, and that's usually the target for going to targeted. The targeted will be pop-up clinic, mobile clinic, drive-through, and the long-term sustainability would be primary care and pharmacy. And we will definitely work with the public and all partners to ensure this plan will be completed as designed. Then the mass immunization, as I mentioned, start ramping down, and the main reason it successfully completed its role. We will see, and we have seen over the past week, less people attending the hubs. So we decided to send the staff who were not needed in the hub to do the primary work in targeted immunization in pop-up clinics and drive-through. So we're ramping the second one up, we're ramping this one down. And that will take us to the targeted for the disadvantaged communities, transient. We've been sending mobile clinics and with the help of the EMS in both Grey and Bruce to roaming home and registered shelters. And that started about a month ago, was completed nicely. We went after to foreign workers on farms. Then we will continue this work, and we do at this point. The other target is the younger people. There will be clinics going to the gyms, hockey games, malls, and usually when you meet people where they're at, it's much easier. And the recent successful clinic was in Grey Highland. Mayor McQueen has been proactive, felt the need and communicated with the Amish and Mennonite community who would have difficulty in transportation. We set up the pop-up clinic. It was a successful experience, and there are other similar experiences throughout Grey Bruce. We have clinics on daily basis now, and we're going to up it going forward. The sustainable traditional vaccine system is pharmacy. We have 35 pharmacies on board with giving the vaccine primary care. 12, this number can increase, and it's usually the case that will increase in the third phase. Health unit vaccine clinics, that will be, the combination will be the sustainable strategy, similar to flu vaccine, and that should proceed probably after August. The targeted will be during August. This will work through August as well, but will be completely ramped up and take the leadership or the main role after. I already mentioned the communication during the past few slides. Targeting the second dose who have already booked in the summer, then targeting people who have not booked has been our main strategy to get the second dose, low-hanging fruit. Then we will go into the communication to encourage vaccine confidence, combat hesitancy. And we've started this even before August 1st, but that was the original plan. Communication on transition from mass immunization to other delivery model has been starting. And again, it is a dynamic process, and it becomes more important, the vaccine levels, because of the Delta. If it wasn't for the Delta variant, we would have already achieved our goal at this point with achieving the herd immunity for the regular COVID. The changes over the past 3 weeks, having the Delta confirmed as 99% of our population, is a really hard finding and a game changer. And that's where you would see the communication from the Chief MOH's office that the fall will be, could be very well a very difficult time for Ontario, knowing that the experience in Waterloo and Grey Bruce can be generalized down the road in Ontario in the fall. Most of our health units in Ontario have not had 100% of the Delta variant, and that's a good thing. If we can increase the vaccines to a level close to 85 or 90, we would avoid that disaster, or the potential disaster, I should say, that is talked about in the fall. And if I can end the presentation, Madam Chair, with one more file. It is related to the cases in Grey Bruce who were identified between July 1st and July 15th. I took all the identifiers from our file from the database, and I'm just going to go through one thing here. The cases that have, or I need to switch my screen again. So this is the direct database we work from. People who are color green have 2 vaccines, and red do not have full vaccination. And there is over 290, I believe, or so cases. And you can tell almost all of them have not received full vaccination. It's a red line mainly. We have 5% of them that have full vaccination, and in general, the experience is less severe disease for people who receive 2 vaccines, and that's a messaging that's going to continue for the coming few weeks, hopefully until we reach the 90%. I'll stop sharing my screen and open to questions as always.
Thank you, Dr. Era. Welcome, Selwyn. Okay, Helen Claire, you have a question or a comment?
I do, Madam Chair. Thank you. Through you, Dr. Ara's presentation drew attention to 2 groups: the itinerant group, marginalized people who are spreading in the community or have been spreading, and also young people who Dr. Ara, I believe, said vaccinations are not on their radar. But looking at the communication plan, although there are targeted segments to communicate to. I'm not seeing a target to those young people. And I'm wondering if there is something that is forthcoming, and also if there has been any thought to incentivizing those young people by using some of our perhaps partners in the community that could provide some kind of incentive that would speak to young people, because I don't think many of them would be interested in golfing. So just that, in sum, that I note that young people are part of the issue of spreading, that I note that the communication plan doesn't seem to be speaking directly to young people with a strategy to involve their, to get their involvement in vaccinations, and finally to see if we can't incentivize that somehow. Thank you, Madam Chair.
Thank you. Dr. Era?
Through you, Madam Chair, I should have elaborated. Actually, the bulk of our communication will be targeting this age group. And there are definitely incentives and disincentives. One of them is working with the On Sound hockey team, On Sound Attack, through their fan distribution list. There are different communication strategies. One of them is to get the champion or peer from that age group. And we have been working on connecting with a famous celebrity, younger individual, Nick Suzuki, to see if we can have joint communication. At the same time, we're working on different methods of communication with younger individuals to influence their peers, having the targeting access in hockey games, gyms, movie theaters. That will be also part of that strategy. Worth mentioning that in my last update to the board, our percent or proportion of younger individuals was flagged as very lower than the provincial average. Right now, we are above provincial average in that group. So those strategies are working, and these coming strategies would also be working even more, since we are targeting in that part. I don't know if I explained it. For the past 3 weeks, we've been targeting mainly the people who booked a first or had their first shot but have not received the second shot. But at the same time, we were focusing on the younger adults as well. It's not like they're left behind. And now we're going to be focusing mainly on the younger adults in the communication. And Drew, I don't know if you have any thoughts about any other items. Like, I know that we have a long list of communication for the younger group.
Yes, I would advise we have significant participation in social media, which is the young people's venue. And of course, peer-to-peer is the strongest influencer in that demographic. And we're working very hard in that area.
Anything further, Helen Claire? That's good. I did hear on the news that some of the universities there, if you go into residence, you have to be double vaccinated. So I hope younger people realize that, because otherwise they're going to be caught, right? So, Brian O'Leary.
Thanks, Madam Chair. Just further to HC's point, I'm wondering if Dr. Era, there's any way of breaking down that 12 to 40 group further, if that would help our targeting message. I'm just thinking of, you know, how protective mothers are. I'm just thinking of that, the group of kids that are under 20 that are still somewhat under the care of their mother, whether that age group is too close to the age of 12, that breaking point, you know, of getting the vaccine or not getting a vaccine. I'm just wondering if there's any way of breaking that 12 to 40 down any further.
Through you, Madam Chair, definitely that is part of the work. The media releases that went out about school exclusion, if there are outbreaks or cases in the schools in the fall, kids who are not vaccinated will be excluded based on the management of the situation, versus kids who are, or students who are vaccinated will not be excluded. Similar messaging or messaging with a similar purpose went to employers to say, and that would be for the age over usually 20 people who are working, to encourage employers to have policies to encourage vaccination of their employees. So there is definitely the breakdown of the different age groups with incentive or disincentive. Worth mentioning, the school system, usually we have mandated vaccines for certain age in Ontario. Few provinces in Canada has that. COVID is not on them. There is a discussion provincially whether we should add COVID, and it seems the inclination is not. So that would increase the need for local solutions based on incentives and disincentives. And again, at this point, we're recommending, and we will see where that will go down the road. There could be policies from the Ministry of Labor or from businesses to ensure that the policies in the workplace would increase the level of vaccine. Back to your question, there are different policies for each age group. To the best of our ability, there are incentives that would work for people that wouldn't work for other people, and we will continue to monitor that. Another example specific is for the teenagers who, or the younger people who would party, to actually work with the liquor store or the marijuana store stores to encourage messaging that would encourage vaccination or safe partying. So we definitely are leaving no stones unturned.
Anything further, Brian? Okay, Selwyn, then Alan.
Thank you, Madam Chair. On the youth messaging piece, I would suggest perhaps engaging youth at Launchpad. You've got a tremendous, already gathering of young people who might have ideas, and perhaps we're looking more towards a campaign for youth by youth. I would think that they've got very different ideas about how they want to be communicated to and with. It could be, we've already got some good partnerships with Whiteman, and I know that Rogers is always willing, and of course our radio stations, but I would suggest that to even engaging some local stars, like Patrick Switzer, who is a world renowned now skateboarder, perhaps messaging from people like that. And I think the young people would probably tell us best, what would and what would not work. But I don't mean to create work for this group, but I'm just thinking we've got a great, facility right there that's, youth-based, and we might want to take advantage of that. I'd be happy to help facilitate that if you thought it would be helpful.
Good idea.
Thank you. Definitely will take you up on the offer.
Yeah. Okay, Alan?
Through you, Madam Chair, Doctor, that was a great presentation, and I hope the media are usually pretty good to pick up some points out of it. So there's all kinds of information that you relayed this morning that hopefully the media will pass on to the general population. So thanks very much for that update.
Thanks, Alan. Anything further? Chris?
Yes, I have a few questions. Dr. Reddy, I noticed looking at some of the stats that are positivities for the testing is very high. 6% of our test results are coming back positive, and that's by far the highest in the province. And I just wonder if you could comment on why that's so high.
So test positivity is one of the metrics through you, Madam Chair. One of the metrics that we look at, and it is consistent with the other metrics, like the average new cases per week is one of them, or the cases per 100,000. The percent positivity is one of the least reliable metrics, just because it's affected by the people who get tested for no symptoms, whether it is for screening to go to a long-term care or the people who just want to be tested without symptoms. So the measure is less reliable. Nevertheless, the fact that it is high, it is consistent with the surge that we have, and the fact that the Delta variant is way more infectious than the regular variant. The regular variant has an R0, which is basic reproductive rate, the number of new cases generated by each case is 2 to 3. For the Delta variant, it is 6 to 9, 6 to 8 point something. So that is different level of transmission, and that's reflected by the number of tests that are conducted.
Okay, so, well, that's just one of the indicators that we're leading in. So I am, even though our numbers dropped this week, I still am very concerned about Grey Bruceby, Ontario's hotspot, and the number of indicators we're leading in. Getting back to the beginning of the presentation, when you were doing a breakdown of how the virus transmits through the community from different populations, have you done do you have a chart on a breakdown of how many people in, I know you talked a lot about transients, how many people in the vulnerable population have caught the virus in the fourth wave, and how many people in the First Nations? So for example, looking at the numbers, I see that in the last week we had 150 cases, and 7% of those were First Nations. So they've done a great job in pushing their numbers down over there at Saugeen First Nation. But do we have a breakdown on the percentage of the vulnerable population that has caught the virus in the fourth wave?
The number is dynamic, as you can appreciate through you, Madam Chair. Early on, the majority of the cases were from the transient community. Then you would see the spillover to different parts of the population. If you look at 1 week, you can count the people who disclose that they have been using substance, or the people who are homeless, and some of the clients might not disclose. So that number will be an estimate. Nevertheless, it was almost all the cases. Then you fast forward over the past 4 weeks, the proportion is reduced. The rough estimate, I would say less than 50% right now, but a good part of the population. If there is interest in the exact number, we can look it up. If there is interest in an exact number within the time window, we could. It doesn't usually change our next step in management, that we need to support these individuals and prevent that further transmission to the population, regardless what that percentage is.
Okay. Well, given the critical nature of those numbers, I had a further question is, what are we doing in terms of epidemiology right now for staffing? Do we have a department doing that? How's that set up for us?
Through you, Madam Chair, can you elaborate on the question, please?
Yeah. So I know, well, just going way back, we did lay off the epidemiologist way back 2 years ago, and that's always been in the back of my mind. Is that something that down the road, which is now, would create a problem? So have we replaced that position that we laid off 2 years ago? And how are we covering for that
Through
work?
you, Madam Chair, we had 3 individuals in that department. We remain to have 2. Both of them are very experienced in what they do. One change happened. We hired a new staff when one of the 2 staff data analysts left the organization, but we do have enough capacity, and the fact that we've managed the last year without effort, we would show that we have sufficient staff. Dr. Zaid has definitely experience in that. Myself, I have a master's in epidemiology. We do have sufficient resources and capacity to manage epidemiology.
Mm-hmm. Okay, and then one final question, jumping ahead. I am quite concerned with our high numbers, how that's going to set up the return to school. We have that amount of virus in the community, and then we have all of the elementary age school children going back to school unvaccinated. I'm quite concerned about that scenario. So what is the what's the prognosis for getting this fourth wave tamped down before September 1st?
According to the provincial assessment and based on the experience in Waterloo, it took around 10 weeks for it to go down to a level that's plateaued. I'm cautiously optimistic this period of time will be shorter for us. As you know, we can see 2 weeks in the future with this pandemic and with the level of infection, things can change. And in the fall, that is about 7 weeks from now, depending on the level of vaccines, depending on the restrictions, direction from the province, and the dynamics of the outbreak at that time, will make decisions to ensure, to the best of our ability, safer reopening for schools.
Well, I know I've mentioned this to you before. I would like to see come August some consideration given to ensuring that the schools have spent their money that they're given on proper ventilation to ensure a safe return to school. So I'm not sure all of that's been covered by the schools. I mean, there's a lot of science out there about ventilation, and so I'd like to tell our parents that we have done our due diligence to make sure that the schools have good ventilation for the return to school.
Dr.
Through you, Madam Chair, the Public Health Ontario is the science agency in Ontario, and they did not indicate that more need to be done there. Of course, more ventilation is better for many reasons. Nevertheless, the measures that we had so far has been sufficient. With the Delta variant, there is potential change, and I trust Public Health Ontario will continue to evaluate and monitor the situation. And if there is change in the recommendation to alter the level of ventilation, we will receive that direction from Public Health Ontario and recommendation. There is a lot of science out there that could be biased by many interests.
Yeah, well, I don't know. The side of the debate that doesn't believe in the airborne nature of COVID, I don't think you have any scientific proof. Most of the scientific proof's on the other side now that COVID is airborne. CBC a month ago did a great piece on it, 10-minute piece. Everybody should watch it.
Through you, Madam Chair, there is airborne transmission for COVID. It is documented, but how much is it affecting the transmission? That's a question that is core. Anything could be airborne if you put enough pressure to generate aerosols. It's just how much of that is causing disease. That is the core question to it again.
Well, I think that side's relying on 100-year-old data.
Okay, you're finished with your comments and questions, Chris? Yes. Helen Claire?
Thank you, Madam Chair. Through you. What we have seen is that children are don't spread as much so far as other people. So I'm wondering, going back to the communication plan and paying attention to what Mayor Peabody was just saying, if there could be some kind of outreach, particularly to teachers. I'm understanding not all teachers are vaccinated, and there is a cohort of teachers who don't want to get vaccinated, and just wondering if that is something that would be a useful approach to work towards, to try to encourage teachers as something that can make a difference And because adults are the ones that so far are the principal vectors, not children. So just wondering about that through you, Madam Chair.
Thank you. Dr. Era?
Definitely, there is value in utilizing all measures that we can. The Delta variant has shown that there is more transmission in children, in all the individuals, but in children as well. So that becomes even more important.
Okay, good discussion, good questions. So let's move on. Next on the agenda, modernization. Dr. Era?
That's a standing item, Madam Chair. There's no update about that.
Thank you. Next, the opioid situation.
Similarly, no major change since last update. All programs that we provide, the core programs continue, and we have been looking at the recovery phase. So we're looking at different changes related to the administration. Nevertheless, the programs continue.
Okay. Selwyn?
Thank you, Madam Chair. If I might, I would just tell this group that at Grey County yesterday, there was an excellent presentation on this issue. And part of that delegation was a call to action for political figures. Grey County moved yesterday to direct staff to come back with a report that responds to this call for action. And so I think that in the weeks to come, you will see that. I think it's an issue, a tremendous discussion yesterday that happened. Quite a bit of time put to it. A lot of concern. I think we've got some people who are doing excellent things, including, by the way, the Board of Health, who are part of that response. In my personal view, I just think that some of those people who are active and are the responders need to be a little bit more vocal and perhaps have the help of some of the elected representatives to do so, to draw attention to this and to see that the appropriate level of resource is put to this. So good news on that front. I was so happy to see that discussion happen yesterday.
Thank you for sharing that. Okay, so I need a mover and seconder to receive Dr. Era's update as presented. Alan, Selwyn, all in favor? That's carried. Thank you. Item 8 is the corporate services. We have the financial report for May of this year.
Madam Chair, I wonder if the in-camera could be inserted at this point, just because it's 11 o'clock.
Yes, we could do that. Thank you for that. So we are going to deviate from the agenda just because of timing. And item 10, in camera, it's been recommended that the Board of Health meet in closed session in order to address matters pertaining to advice that is subject to solicitor-client privilege and to consider personal matters about an identifiable individual. I need a mover and seconder to go in camera. Brian Millen and Helen Clare, all in favor. That is carried. Thank you. So we'll just wait for Connie to stop the live. I'll still wait. I'll wait for Connie to say go ahead. That's the hardest thing. You see it on the screen that it's live, but you're not really live. So Mary or Connie, please let me know when we can, when I can start.
We are live, Madam Chair.
Thank you. So we are now in open session, and I declare we discussed only the items that were listed on the closed meeting agenda. We approved in-camera meeting minutes from June 25th. A personal matter about an identifiable individual was discussed, and direction subject to solicitor-client privilege was received. And I will ask the Vice Chair to confirm that did take place.
And I confirm your statements, Madam Chair.
Thank you. So now we will continue with our agenda, and we're now on item 8, which is corporate services. We have the financial report from May 2021. So Matt.
Thank you, Madam Chair. So we have received on the 22nd of July from the Ministry of Health approval for our 2021 budget. And included in that approval is 50% of our COVID-19 response. So that's a combination of both the vaccine and the case and contact management. That approval amounts to approximately 2.4 of the 4.7 that was asked for. So that's and they do term it that way, that it's roughly a 50% approval at this point. What that approval also does give us is a mechanism that is meant to continue to provide funding to the organization to meet the ongoing response to COVID-19. It's not the end. It meets the expectations that they've been setting with us on the starting of the funding, and that it will continue to persist throughout 2021. There is no specific mechanism talked about for 2022. This is just about 2021. So while we have asked for 4.7, the 2.4 is already approved, and they are saying for us to continue our good work when it comes to the COVID-19 response. And as we report now quarterly to the ministry, additional funding that is required will be processed through. They do not want to be providing I'll say blanket coverage. They want to be able to say, look, this is what you spent your money on. It was for COVID-19, we approve. So they want to go back to their normal modus operandi, but they are giving us that mechanism to do just that. Really good news. Overall, it's exactly, I think, what we were expecting. The total amount of the approval was everything that we had asked for when it came to base funding and the other one-time funding that was included, which includes, so it's a re-announcement of what they had previously indicated, but the $1 million mitigation funding for the change in the funding formula from 75 to 25 to 70-30. So that mitigation funding is in place for 2021. And now we have the specific number for it. So that at the end brings us to the contributions that both counties need to make is the same as it was in the previous year. Assuming that population hasn't changed any, then it'll be the exact same for each county. If population has changed slightly, then those numbers, it's based on a pro rata basis. There are some important pieces to this. We have Ontario's senior dental program, capital funding being persisting throughout this year, as well as the operational funding. In addition to that, we also have some school nurse funding that had been talked about, but has now been approved. So that'll actually carry us all the way through to into 2022. But they've given us specific funding for 2021 and for the first 5 months of 2022. So if we were to then look at the financial statements, there is some comment about both the revenues and the expenses. So we are below our expenditure level slightly. So if you were to look at the financial statement with that funding announcement, that indicates that our actual compared to budget, we are in a surplus position of year-to-date of $300,000. So that just shows that we are being prudent in not only that we have obviously overspend, but being prudent in that we're not breaking the bank. We are holding to what our original budget expectations were. We're very close to it.
Thanks, Matt. Are there any questions? Helen Claire?
Yes, thank you. Through you, Madam Chair. So if I've understood that correctly, we have about half of our shortfall being met by the provincial government. Is that because we have met the marker for 6 months of the year? In other words, can we anticipate that the potential for the remaining 50% of our shortfall at the end of the year? Is there a possibility of that? Just looking for some clarity. Thank you, Madam Chair.
Matt?
Thank you, and through you, Madam Chair. I think there's a high degree of certainty that the balance of our funding will come through, assuming we need to spend it. I think that is part and parcel to the way the ministry has crafted the mechanism, is that as long as we need to spend it and it is in response to the COVID-19, then they are covering. Does that answer the question?
Yes, thank you. So just reasonably no change, that the province appears still to be covering us, being a backstop, and we can reasonably presume that that will continue if we indeed meet the shortfall that we're currently looking at. We can reasonably presume that unless there's a change, that at the end of the year, the province will continue to backstop us.
That is an accurate statement.
Thank you. Any other questions? Selwyn?
Thank you, Madam Chair. Matt, you mentioned a 300,000 surplus. Where will I find that in these statements?
So if
page 41?
I don't know that I don't have a page number on this through you, Madam Chair, but it is on the statement of operations. And it is if you're looking at the columns, it is your fiscal year to date. And then there's the actual budget, and then the over short compared to budget. And that is showing the surplus of 303,194. So we did send out a updated version of the financials and the memo late yesterday. So if you had printed it off before that, you were looking at something that looks more like a $1.6 million, $1.51 million shortfall. And because we received, I'll say the first half of the year's financing, we took 5/6 of that and put it into the May statements.
That's my problem.
Okay, no worries.
Good. Anything further?
Madam Chair, just a note, we received the confirmation letter yesterday late in the day, and that's where the revision happened.
Okay. Makes sense. Okay. All right, so I need a motion to receive the May 2021 financials as presented. A mover and seconder. I have Alan and I have Brian Millen, all in favor. That's carried. And I made the executive decision that we're going to push through rather than taking a break. Item 9, is there any other business? Seeing
no
none.
other business, Madam Chair.
Sorry, Dr. Eyre, you said yes?
No other business, Madam Chair.
All right, thank you. So one final item, and that is to adjourn at 12:36. I need a mover and seconder. Brian O'Leary and Selwyn, all in favor? Carried. Thank you very much. Have a great weekend.
Bye, everybody.